Good morning. I believe this is Monday. Is this really Monday? Yeah. So help me. Let me hear you say Monday. All right. Well, all right. That means this is an anticlimactic situation, but it is said that we spend approximately 1/7 of our lives on Mondays, inasmuch as there are 7 days in the week. So you can't have Sunday without Monday. So we want to welcome you on a Monday morning. We appreciate Dr. Wayne Tuckson, our facilitator, being with us today. Yesterday, the HEAL Initiative was introduced. I believe Ms. Danielle is here, and Dr. Mole. We certainly appreciate you, and thank you for coming. I know that many people have employment responsibilities on Mondays as well as other obligations, so you are here at a sacrifice. We want to appreciate you putting health, number one, on your agenda. The word says, I wish above all things that you may prosper and be in health, even as your soul prospers. So let us pray. Eternal God, we thank you that the church is a healing place, a place of binding up wounds, broken hearts, lifting up heads that are bowed down. Thank you for the magnetism of Christ, who says that our distinguishing characteristic is love. By this shall all know that you are my disciples, by the love that you have one to another. And nothing heals like the power of agape love. May we feel your love today as we are made aware of how we can help to improve the quality of our lives and others. In the name of Jesus we pray. Amen. Dr. Tuckson. Great Dr. Fields from Milwaukee, Wisconsin. Will you stand? He's the one that's responsible for this happening. So let's give him a hand. We appreciate you, Dr. Fields.
And welcome to everyone that's here. We're glad to see you. I am Wayne Tuckson. I have the pleasure of being the moderator. Before we begin, let me ask, first off, I want to say you all have your package. And if you notice in your package, there's a sheet that has a pre-evaluation survey. We would like you very much to fill that out. And at the end of the program, we want you to fill out the post-evaluation survey. Now, if you want to cheat, because you know this is going to be a wonderful program, you can go ahead and fill them both out right now. But I think to be fair about the whole thing, please, if you would, for right now, make sure you fill out the pre-evaluation survey. Before we begin, how many of you know, how many kidneys do you all have? Anybody know how many we all have? 2. All right, very good. Anybody know where the kidneys are located? Okay, where they located? All right, very good. What do the kidneys do? Filter fluid. Okay, anything else that they do? Purify stuff. Okay, anything else that they do? No, we're going to find out a lot more stuff later on today. And anybody know what some of the signs of having kidney disease are? Yes, ma'am. What'd you think? Yeah, what are some of the signs of having kidney disease? Just something real quick. Yes, ma'am. Joint swelling. Okay, body joint swelling. Anybody know any of the reasons one can have kidney disease? Yes, ma'am. High blood pressure is the big one. Yes, ma'am. Diabetes. Okay. So in other words, there are a lot of things like this we're going to talk about. Anybody know the treatment for kidney disease? Dialysis. Is there another treatment for kidney disease? Medication. Is there another treatment for kidney disease? Yes, ma'am. Kidney transplant and medications and transplant. So these are some of the things we're going to talk a little bit about today. And if somebody tells you you got kidney disease, can you eat anything that you want to eat? No, I mean, that's the saddest no ever heard. No, we can't eat everything we want to eat. We got to make sacrifices, don't we? And we're going to hear a little bit about that too. So we're going to talk a little bit about the journey with kidney disease, things that we can do to keep us healthy, some of the signs and symptoms of kidney disease, some of the things that get us in trouble and give us the causes of kidney disease. And then we're going to sit down and try to find out how we can be proactive in our own interest. So bear these things in mind. We're going to have several speakers that are going to come up here and speak to us today. You all were handed out little cards. So during the course of things, if you hear someone making a statement or something and you want to know a little bit more about it or you want to ask a question, write it down on the card. We'll pick it up and we're going to try to ask as many of those questions that you all write down. I can tell you right now, if you don't ask a question, I'm going to come up here and ask you a question. You know that old trick, Well, I went to school ended at 3 o'clock. And so at 2:30, I was asking every dumb question I could think of to keep that teacher from bugging me before 3 o'clock came along. Because I didn't want to sit there after school because I didn't know the answer. So you want to do that for us too. So to get things started, I'd like to bring forth Mr. Howard Mosby. He's a former Georgia State representative, and he's the corporate treasurer for the Heal Collaborative. As he's coming down, I want to thank Mount Airy Church of God in Christ for hosting this event. Please give a hand for Mount Airy. And this is a collaborative effort with the Heal Collaborative and Ardalex Pharmaceutical. Representative Mosby.
Good morning. It was great being here on Sunday. Bishop did a wonderful job. He laid out the framework here for what we are going to deal with here today. And although we're talking about chronic kidney disease, it really is about the health of our community as a whole. And if we're not interested in making that better, you can't be a great servant for the Lord. If you're sick, you don't tithe. If you're sick, you don't work. So it's about you actually being better to do God's work. And so we're here to talk about kidney disease, and it is indeed our honor as an organization to bring this program to lock arms with this ministry. This has been an awesome, we have been all over the country. Let me just say this. We've been all over the country. And Mount Airy, I would say, is probably one of the premier ministries that we work with to really wrap their arms around us and bring this program to you. So I just want to say thank you. Give yourselves a hand. Heal Collaborative really is an organization we are built to help our community be healthy. And that's it in a nutshell. So if you look at oncology, you look at cardiovascular, metabolic disease, renal disease. These are areas that we're working with that have always shown our community having an issue in this area. And so we want to make sure that we bring this information to you. We're bringing in trusted experts. If you had to go to a doctor's office to get the kind of time that you have these experts here, you would never get this. And so you have an opportunity to ask your question. You heard Dr. Tuckson ask you to ask your question. This is your time. These folks are here. There is no dumb questions here. There are none. Ask the question that you want to ask. These individuals are here to bring this information to you. So we're proud to be here. Ladies and gentlemen, on behalf of Heal Collaborative and the board of directors, thank you. Thank you, Bishop, for allowing us to be here, being in your house. And we're going to do a great job for you, sir. Thank you. Thank you.
And Mr. Mosby, I know when you made your comment about the wonderful edifice in which we're in right here, Bishop Felton's house, you did not neglect Milwaukee by any chance, did you?
Pastor Fields is the individual. Stand up again. Pastor Fields out of Milwaukee. We did a program in his church. He said, I want to be a part of this. Not only that, we told him we were coming to Philadelphia. He said, let me tell you who you need to get with. He said, go to Mount Airy. He didn't say Enon. He said Mount Airy. Okay? So that's why we're here. We're here. Awesome man of God. Awesome story. And let me just say, we wouldn't be here today without him. So thank you, sir. All right.
You give her that. I'd bring up our first speaker, Ms. Jasmine Evans. Ms. Evans is going to talk to us today about living with chronic kidney disease. So that you will know, Ms. Evans was diagnosed as having kidney disease back in 2017. She attended Kent State University. She did her master's work at Temple and also is now a PhD candidate at Temple. The remarkable thing about all of this, she did all this stuff while she was on dialysis and getting ready for a transplant. I don't know about you, but that takes a lot of stuff. Thank you. So again, Ms. Evans is going to speak to us about living with chronic kidney disease, my story, my journey. Ms. Evans.
Thank you so much for that. Thank you for such that warm welcome. I definitely appreciate y'all. Now, I was raised Southern Baptist, so I would like to start off by saying giving honor to God, right, who's the head of my life, to the pastor of this church. Thank you for allowing us to have this, to the deacons, the ministers, to the entire church family, and all of you for coming out on a Monday. We really do appreciate you guys for being here to Hill Collaborative. Thank you so much for allowing me to be a part of this very important conversation. So again, I am Jasmine Evans. A little bit about my story. I was actually diagnosed with chronic kidney disease in 2012. I was a senior in high school, about to start my journey at Kent State University. I was so excited to go to college. And then one day I got a physical, and my primary care, she said, "We found protein in your urine," right? And protein in your urine is not normal at all. It should not be there. Once protein is in your urine, something is going on with your kidneys, right? It's not filtering the way that it's supposed to. It's keeping toxins in and dumping things that don't necessarily need to be dumped out, right? And so she said, "I'm sending you to a specialist, to a nephrologist." And it took a few months of testing. They couldn't really figure out what caused it because it's not genetic, right? I'm the only one in my family who has had to deal with this. It wasn't because of diabetes. It wasn't because of heart disease. It wasn't because of any of that. But what they did find was that I had uncontrolled hypertension, right? Even as a 17-year-old. And we kind of looked back at my medical history, and when I was 12, a doctor told my mother, like, "Hey, we think she may have pre-hypertension, but it's nothing to worry about right now. She's 12, right? She'll either grow out of it or grow into it." Guess what? Neither one of those things happened, right? And so that caused damage to my kidneys. It meant that one kidney had stunted in growth. It wasn't as strong as the other kidney. So my left kidney, my strong kidney, basically had to do all of the work. And so that's what ended up causing my kidney disease. So fast forward to 2017, at that point, it was managed through medication, right? As long as I was on high blood pressure, as long as I was using the bathroom like I was supposed to, right? Drinking all my fluids, then everything was okay. So I thought. In 2017, I was graduating from my master's program. I had just got accepted into my PhD program, and I'm so excited, right? I'm doing research on medical racism, the history of it, right? And how it affects our communities. And I remember I was at work, and I got the call from my nephrologist, and she said, "We need to start talking about dialysis," right? Because your GFR score had basically dipped below 15%. So basically what qualifies you for a kidney transplant or for you to go on dialysis is that your kidney function is below either 20 to 15%, right? I had finally dipped below that line. And so I did peritoneal dialysis for 4 years. I did it at home. And it was hard for me, being a 20-something-year-old in a new city, a new state. My family is spread between Mississippi and Ohio, right? I don't know nobody out here in Philadelphia, and I'm going through this life-changing thing virtually by myself. And as a young woman, that was hard for me, right? It was very challenging. But luckily, God put people in my community and on my care team that was like, "You know what? We have your back," right? And so every time I tell my story, I give credit to my first dialysis nurse. Her name is Leah Santos, right? We're still in contact to this day. I remember I was in my clinic and I was just crying, bawling my eyes out, because I was like, I can't do this. I can't be in this very rigorous academic program, and I'm away from my family, and y'all want me to do dialysis? Who's doing that, right? Not me. And she sat me down and she was like, Jasmine, I need you to understand something. Dialysis is temporary, but your life is gonna last a lot longer. You have to start preparing for your life outside of dialysis. And that's exactly what I did, right? So I continued on into my program, and now, finally, in the final stages, right? I'm writing my dissertation. I'm hoping it'd be done by May. And I just continued. I continued working. I continued posting on social media about my story and telling people and educating people about this disease that's a silent killer in our community, right? And that not a lot of people knew about. And so one day, March, actually, of 2023, I get a letter in the mail from UNOS, which is the United Network of Organ Sharing. And they basically told me that during my transplant evaluation process, and even throughout my entire course of care, that they used a specific algorithm to determine, right, my kidney function and how they would basically give me a course of treatment. And that was called the GFR, right? And I believe we're gonna have more people that'll talk about that, but I'll tell you how this algorithm affected me. Now, with the GFR, it basically tells you what your kidney function is, right? So y'all remember when I was telling you about like if it drops below 20 to 15%, that's when you're eligible for a kidney transplant, that's when you're eligible to go on dialysis. Well, the EGFR overestimates Black people's kidney function, right? Whenever they were developing this algorithm, they noticed that Black people were testing higher routinely. And instead of doing their due diligence to see why this was, they came to the easiest conclusion: it must be because they Black. Right? And we understand now that race is more so a social construct than it is something that is biological, right? Our bodies don't work differently than other people's bodies, right? And so UNOS finally did something about it, and they did away with the eGFR or the GFR calculations, right? And they told me if we were to reevaluate your scores, it would mean we actually took 4 years away from you on the transplant list. So to give context, right, let's do some backtracking. I was diagnosed in 2012. In 2017, that's when they told me that I needed dialysis and a transplant. But whenever I got this letter and they reevaluated my scores, they actually said we should have had you on the transplant list in 2015. And because of that, we are going to give you accrued time on the list. And so I'll never forget it. One day, it was Monday, July 3rd, 2023 at 7 p.m. I was cooking dinner, right? And I had gotten a couple calls before about like potential kidney donors. And I had saved the number in my phone under these like really big capital letters like your kidney is calling. And someone was calling my phone. I'm like, who calling me? Y'all interrupted my Sade. Like, I'm trying to listen to this music and cook my dinner. Like, what y'all doing? And I saw those letters flash. And I immediately picked up the phone and they said, we have a kidney for you. You need to come right now, right? Thank you. And so on July 4th, I received my kidney transplant. So now I say like the fireworks are for me. And I just thank God, right? Because I was really at a place where I was like, you know what? I don't know if I could continue this anymore. And then I got that letter in the mail, and then I ended up getting my transplant. And that just emboldened me even more to continue to not only tell my story, but to continue to educate people, right? To say kidney disease, not only is it a silent killer, but we also have other things, other tools that are working against us as Black and brown people within the medical system, and we have to continue to advocate for ourselves, right? We have to continue to hold our medical professionals accountable for these outdated algorithms that they're using, for not giving us the care that they need. And so today, not only am I writing my dissertation about that topic, right? I'm also empowering not only patients, but community members like yourselves to really be an active agent in your own medical journey. You can't leave it up to them, right? You have to also do the due diligence yourself to ensure that they are giving you the care that you deserve. Because if not, you could end up like so many other people, and I pray to God that that never happens for us, right? I tell people all the time, I'm just one success story, but there are so many other people who could be standing in this place as well. And I'm so proud to be among the 14,000 Black Americans that not only got accrued time, but the 3,000 of those who received a transplant, right? It was a delay, but it wasn't a denial. And I praise God for that, so thank you.
Thank you very much, Jasmine. I think that you kind of gave credence to what Bishop Felton said. They said that 1/7 of our time is spent on a Monday, but I think you showed how important Mondays can really be in terms of getting these kinds of notices. Thank you very much for that. I'd like to bring up our next speaker. It's going to be Dr. Getson Hall. Dr. Hall is going to speak to us about living with chronic kidney disease. Dr. Hall got his MD and PhD degrees simultaneously, and he's probably the only person that can understand the struggles of spending time getting a PhD degree that Jasmine just talked about. But he got those at the University of Maryland. Following that, he did an internal medicine residency in nephrology, and he also did fellowship in nephrology, both at Duke, where he's currently an assistant professor of medicine in nephrology at Duke University School of Medicine. Again, Dr. Hall is going to be speaking to us today about living with chronic kidney disease, prevention, screening, and kidney disease management. Dr. Hall.
All right, good morning. I just want to say there will be a number of voices you'll hear, but honestly, nothing as important as what you just heard from Jasmine. Please give her another round of applause. That is the entire story that I want to communicate, but just from a different angle. And so hopefully I will be able to give you a sense for what the doctor is thinking and wanting to communicate to patients, hopefully so that we can have as much of a success in all of us who struggle with this issue. So I did prepare some slides. I'm not sure if I'm just going to use those as sort of milestones to give you a sense for some key items. So this is sort of my way of modifying the title, but it's really intentional. It's chronic kidney disease, what to know and how to respond. So in that statement, what I'm intending to convey is that education is one thing, but action is another, and you're responsible for both. So I'm going to help you with that, but as you've been educated, once you leave, having heard all of this testimony, I want you to take it outside of the church and explain to other people who may not know their risk, may not understand their risk, what you heard and where they can come to get additional information, okay? Next slide, please. All right, so we had a really good quiz in the beginning. I'm glad I didn't do one first because but I like to start my talks with a quiz, and so I'm glad it got done, and you guys did perfectly well. But here's some points about how the kidneys work. So you have 2 kidneys in each body, right? Several of you mentioned that. But you have, think of in your water filter at home, that little cassette in the filter. That does all the water filtration that you need for a few months. Well, in the design of your kidneys, you were given 1 million little filtering units in each kidney. That's supposed to last you a lifetime and even beyond, right? So that is a miracle of design. And those little filters are called nephrons, okay? The kidney actually filters your blood. It removes waste. It regulates salt balance, so things like sodium, potassium, chloride, phosphate, all those things that you have to be conscious of when your kidneys stop working so well in terms of your diet. That's what your kidney does for you 24/7 when you're asleep, when you're awake, when you're exercising, when you're not. Kidney is circulating your entire blood volume 70 times in a day. So this is an intentional process that keeps you in balance, and it's completely silent. You don't know what's happening right now. Okay? The kidney also produces hormones. So how many of you know what insulin is? Okay, so insulin is thought of in most instances as a medication for people that have diabetes, but it's also produced by your pancreas and, surprisingly to some, also by the kidney. So that's an important function that it serves. It produces hormones that regulate your blood cell number. So it produces a hormone called erythropoietin, don't have to remember that, but it goes to the bone marrow, stimulates the bone marrow to produce red blood cells. So what you'll notice when you're starting to have symptoms related to chronic kidney disease, one of the symptoms that people complain about is fatigue, being short of breath. Some of that is related to the fact that your red blood cell production starts to go down. Lower red blood cell number you have, less oxygen you can carry around, the more tired you feel. Kidney is really important in a number of ways. It also returns essential products back to the blood. So you can think of the filtering system as agnostic in a sense. The first pass is just filtering everything more or less by size and by charge and other sorts of things like that. But the kidney has a very complex mechanism of recovering the things that it actually wants to keep in the blood, taking those out of that filtered fluid and putting them back in the blood. So you're not intended really to waste anything. That's important. So if your kidney can't do that for you, you're potentially losing quite a bit of valuable material that your body needs to do its work. The kidney preserves the pH balance of your blood. So that's really important because your blood goes to all the tissues in your body, feeds them, it's the nutrient source, it delivers oxygen, and pH is a very important aspect of that whole delivery system. When it starts to break down, part of that is going to be manifest in the symptoms that you experience. That's an important thing to know about the kidney. It regulates blood pressure. It's sort of a chicken and the egg thing. When people think about it, or when it's described to us in medical school about the kidney and how it regulates blood pressure, there are active things that the kidney does to regulate blood pressure. However, when the kidney starts to fail and blood pressure gets worse, that elevated blood pressure can also damage the kidney further. So it's sort of a cyclical thing. So I just want you to be careful when you think about high blood pressure. Jasmine mentioned this as something that you'll grow into or something that you don't have to worry about now. Not at all. It might be the first signal that something's going on in the kidney. It also gets rid of excess fluid. Someone mentioned joint swelling. Well, it tends to be the case that more than your joints, fluid will accumulate everywhere when the kidneys aren't working. It's obviously where your body gets rid of urine. Urine is fluid. A lot of that, most of that is water. And so if your body can't get rid of that water, most of it coming in through diet, it starts to go to other places. So it starts to settle in the tissues of your body. So you start to see it in your ankles, sometimes in your fingers, in your face, depending on what the nature of the problem is in the kidney. So it definitely handles fluid balance, and that's something that I think we should spend a little time on a bit later. It cleans your blood volume. And I've mentioned this, but I'm saying it again. It's on the slide. I'm saying it 70 times in a day. That is an incredible amount of work. So your heart is pumping, pumping, pumping. Kidney is seeing all that blood come through, and it is constantly cleaning it. You know that when you have your filters at home, you have to take your filter out, change it every few months if you want clean water. Kidney is self-cleaning in that way. So you're not taking your kidneys out, having them cleaned, and then returned to you. This is a process that it manages on its own, and it's doing it over and over and over. When you're awake, when you're asleep, when you're exercising, when you're not, it's always there to perform these functions. Next slide, please. So then what is chronic kidney disease? Well, it's any condition that harms the kidney that goes on for an extended period of time. Sort of a broad way of thinking about it. And it can be caused by a variety of conditions. After your talk, Jasmine, I'd like to talk to you. You said it's not genetic. I just have to ask you a couple questions about that because not that I want it to be, but I just want to know what you've done to genetic kidney disease, as we understand it in nephrology, has taken on a whole new meaning for African Americans. There's a subject that I won't really go into detail today, but I encourage you to look into. It has direct relevance to what happened to us in the Middle Passage and the whole question of how certain genes changing in certain contexts to benefit us when we are abruptly taken out of that ecological environment and placed into another can have a whole different meaning in that new context. So I will talk about apolipoprotein 1 only briefly. Hopefully, if you have questions and you want to find out a little bit more, we can talk about it. But genetic kidney disease for African Americans it's a subject of a renaissance actually that we're having in nephrology right now that I really want you to be aware of and involved in at points when you can be. Yes, ma'am.
Why don't you hold that on until you finish, and then when we come back to the end, I know there's some important questions people will have. But just write it down for us, and then we'll come back to it. I promise we'll get to it.
So kidney disease can actually progress very quickly or it can be very slowly. It just depends on the inciting event. So high blood pressure can drive it very quickly. High blood pressure can just sort of be with you over decades, slowly cause you to drift into kidney failure. So there's no way to actually predict what the impact of a particular situation is going to be on your kidney health. What you have to do is to, one, maintain good contact with a primary care physician who, just like they did for Jasmine, saw an early clue and alerted her to that transition of care. I am no longer capable of managing this problem. I'm referring you to a nephrologist who has a better capability. So that's what you want to do. One of the things I'll say later on in this and over again is time is kidney. Despite what we can do, the most important thing that helps doctors take care of you for this issue or any issue involving your kidney is time. If you give us more time to work with, we can do a better job. If you're coming to us in the later stages of kidney disease, we can certainly help you to get you, try to preserve your remaining kidney function, but getting you maybe to the next phase of renal replacement therapy or dialysis or transplant is usually the only thing we can do. So keep that in mind, that these aren't issues that we can sort of sit around and wait for. This can lead to an accumulation of toxic waste products in the blood. Jasmine described that, where you have sort of the swelling, the fatigue, things that just sort of build up because the kidney can't get rid of them. And sometimes some of that builds up because of what comes in through your diet. So one question I get all the time is, well, what can I do in my diet to change this? Well, there will be better experts than me because, believe it or not, doctors don't really get trained in nutrition. And in nephrology, it's a question that we're actively looking into. But Deja's going to be one of our speakers, and she'll give you a better sense for what you can do with diet. Generally speaking, most of our recommendations have to do with before you get to the stage of advanced chronic kidney disease, things that support healthy weight and lower blood pressure. After, we're trying to manage the metabolic derangements that come with late-stage chronic kidney disease. And so the recommendations change a bit. But broad categories, we don't have as much advice to give. And so it's an area that we're still working to figure out. You can actually increase your risk of developing other chronic kidney or chronic health conditions just by having chronic kidney disease. Heart disease is one. Strokes, anything that deals with the vasculature, your blood vessels. High blood pressure when the kidney fails is a common problem, but high blood pressure tears up the blood vessels. So anything that affects the kidneys, you can think of it as almost having radiating effects. So it's something that once you know about it, you really want to be on top of it. Next slide, please. Next slide. Okay. So how common is chronic kidney disease? Well, we heard 1 in 7 earlier. It had to do with the days of the week that we spend on Monday. But actually, 1 in 7 adults, so that's about, in this population, based on current estimates, about 37 million people are estimated to have chronic kidney disease. Because chronic kidney disease doesn't generally hurt. How do you know when you have a problem? What makes you go to the doctor? Something hurts, right? This is not one of those things, or rarely is it one of those things. Things like kidney stones hurt. But not, if you're not talking about kidney stones and you're just talking about chronic kidney disease, it's not necessarily a painful thing. That's why a young Jasmine could go that far in her college life, approaching a major transition, and be more or less unaware because there was nothing physically bothering her that signaled my kidneys are an issue or more of an issue. Of that 37 million, 90% of those with CKD, if these are people who don't know that they have it, right? And these are people who are potentially walking among us. By the way, how many people know someone on dialysis? Just raise your hand. Okay. That is what it looks like walking in these units. Looks like a barbershop. And I have, it's some of the most fun I have all week because you go in there and you talk to people and you relate to them, and it is a good time to speak to them and to get a sense for who they are. But they're really sick people, my people. So that's why I'm here. I want to increase the awareness of this problem and how common it is so that you can start having conversations that get you to the attention that you need. 40% of U.S. adults with severe chronic kidney disease, stage 4, stage 5 kidney disease, and we'll talk about the stages later, don't know they're at that stage. CKD is slightly more common in women, only by a couple percentage points than it is in men. And the rates of it increase with age, as you might imagine. Obviously, you get past a certain point, those warranties start to expire, parts start to run down. One would expect that would happen with age. But as compared to, say, someone in the first couple decades of life, 6% relative to a person beyond the age of 65, 38%. That's quite a substantial difference. Now, you're going to lose a little bit of your kidney function normally with every year of life. It's not, that's just the way it works. But it's diseases like diabetes, hypertension, things that accelerate that rate of loss. So instead of losing like 1% a year, which is normal, talking about maybe using 5 eGFR percentage points a year. And that's what we're trying to slow down. Think of the nephrologist as, those old Western movies where the cowboy would see the horse running by, no one's riding it, and he would run up on it and jump and try to yank the reins to slow it down. That's the position we're in. That's our posture. We're just trying to slow it down. There are very few instances when we can completely stop it. So what we need is time, because that horse is usually in the movies headed off a cliff, and that's what we don't want. As it relates to race, Black and Hispanic Latino adults have a higher risk of kidney. You wouldn't, that's not anything that surprises you, I wouldn't imagine. But to see the actual numbers, Blacks are about 16%. Blacks have chronic kidney disease. We're only about 14% of the population. Hispanic Latinos account for about 14%. Relative to Caucasians, about 13%. So, those are numbers to be conscious of, particularly as it relates to some of our new understanding about chronic kidney disease and how it manifests in our families genetically. Next slide, please. So what are risk factors for kidney disease or chronic kidney disease? So heart disease, blood pressure, and like I said, some of this is cyclical. One begets the other. But certainly diabetes and hypertension are the main drivers in our community. That's for sure. Overweight can be a significant driver of it. And usually with that come diabetes, hypertension, or at least a higher risk and incidence of those. Family history of kidney disease. We are coming up on a couple major holidays, right? Well, we did have one and we're coming up on another, where families tend to get together. And this wouldn't be the type of thing that you normally talk about. But I encourage you, especially for Christmas, strike this up in conversation with your families. Everybody plays spades or something like it, Uno. You can have this conversation at the Uno table. My wife is a kidney doctor too, and our kids are 8 and 10 in the home. We always talk to them about chronic kidney disease. We always talk to them and that is you have to ask them what they think about it. But that's the way we use our time, because we want them to be aware and we want them to think about it in the context of other things that they might be at risk for. I encourage you to have those conversations. I know that it's difficult and sticky and people don't like it, but this is the only way we get to the help we need with the time that we have. Older age, as I already mentioned, low birth weight. So when you start out at a lower birth weight than normal, that 1 million per kidney, those filters I told you about, you won't necessarily have that many. And so if you're starting off with a lower number, you have to run that distance of life. You may run into chronic kidney disease a lot sooner. So for those mothers that are considering family planning, or that are in the middle of family planning that or caring little ones, you want to be very careful to keep those appointments, make sure that the baby is healthy, that all the indices of health, that you're aware of them, and that you understand what's going on with that baby. And also ethnicity and gender, and we'll talk a little bit about that as well. Next slide, please. So how can I find out if I have it? Well, you want to get your primary care doctor, that relationship established early. Any other condition you have that's chronic, you want to get that under control with your doctor's help. You want to know your numbers. You should not walk into a doctor's office, just like any other transaction. You should not walk out without the thing that you came for. What you're coming for when you're talking to a kidney doctor is your eGFR, which is essentially your kidney function performance number. You want to make sure that it's normal, and if it's not in the normal range, that you know where in the abnormal range it's falling. If it's abnormal, you want to know the doctor's plan for how to maintain it where it is, help it to get better if it's possible, or how long until you'll need advanced services. You want to engage in some lifestyle changes to the degree that you're able. You want to advocate for yourself in the doctor's office, in places like this, out in the community, so that not only you know about it, but that others will know about it too and benefit from your wisdom. Talk to your family. I've said it before, I'll say it again. And not to get discouraged. Even though it's a health condition, you want to be as clear on what the options are as you can, and to sort of live in that optimism that comes from that. Next slide, please. The way that we measure kidney function, we'll do tests of your blood and your urine. What Jasmine was speaking about for the eGFR calculation, that's a blood test. She also mentioned protein in her urine. That's what we follow to test for what they call glomerular disease. But those are two tests that we would do. That eGFR is essentially your percentage kidney function. Important number to know. Please make sure that you have the doctor state it and repeat it to you and explain it, even beyond what I'm sharing with you today. Those estimates of your kidney function help you to conceptualize how many of the remaining filters that I have are actually working well for me. And as I mentioned earlier, you're supposed to lose a few of those a year, or that in terms of the percentage of function. But diseases like diabetes, hypertension, they will accelerate that rate of loss. So you want to know what's the difference between the last time I got my eGFR checked and this time I got it checked. That transition is important. You need to know that. So here are the stages. It may be a little bit hard to see it from here, but there's stage 1 through 5. And for our purposes as kidney doctors, it's subdivided even further. But as you can see, that as you advance through the stages, that purple filling of the kidney goes down, 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 down. So what we're saying is, as kidney doctors, we just want you to know where you are in this rating system. And you should have your doctor explain it and give you a sense for what's happening. Next slide, please. And this is the last one. So I hope that it's been informative and maybe to a degree encouraging. I know there were questions that I didn't get to answer, but I'm glad to stick around and maybe answer some of those for you. Chronic kidney disease can occur in the young and the old. As Jasmine mentioned, this happened to her young. So it's not necessarily the case that, I'm not going to have to deal with this until I get to be 50 years old. Remember the saying, time is what? Okay. Yes, it very much is, and I want you to think about this problem in that context. Be aggressive about establishing primary care, and ask the question, if your kidney or primary care doctor says, I'm noticing some changes in your kidney function, ask the question, do I need to see a specialist? Ask them that, because it might make them think about it. 15 minutes is not a lot of time to see patients. And when you have 40 patients in a day, you got to get them in and out. And make them think about it by asking the questions. Advocate for yourself in that way. Work with your doctors to manage your chronic health conditions, so diabetes, hypertension, don't let it go. Get on it and stay on it. There are tons of good medications now, more than maybe what your parents had available to them, that can help you manage things like diabetes and hypertension now. And talk to your families, please, 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 please. Share this family history. I can't tell you how many times patients will come in. One patient comes in, sees one nephrologist. Another patient goes and sees another nephrologist at another hospital. Never a conversation between them. We don't speak to each other that way. You have to know that this might be something going on in your family. And then say to your doctor, hey doc, I have some other people in my family who have kidney disease too. Can I bring them in to talk to you too? Or can you reach out and talk to their providers? That's how we pick up on something might be happening. All right? I think that's what I'll end with. Thank you for your attention. Sorry if I ran a little over.
I'd like to remind everyone that at the conclusion of all of our speakers, there will be a panel where we'll have a chance to ask questions, and I promise you will be the first question that we will have after this. Dr. Hall, I admire that you sit around and talk to your family about kidney disease at the dinner table. Being a colon and rectal surgeon, the last thing my son wanted to hear from me was a discussion about chitlins. I promise you that. Never could get him to talk about that. I think Jasmine made an interesting point about the relationship that she had with her dialysis nurse. And I think there's, in the world of nursing and in healthcare, there are probably fewer relationships between patients and healthcare provider than that with the dialysis patient and the dialysis nurse. There's a unique relationship, and I think we're going to hear a little bit more about that. Our next speaker is Dr. Lillian Pryor. Dr. Pryor is a nephrology nurse. She's graduated from her BSN from Seton Hall University and received the master's degree from Keene University, and her Doctor of Nurse Practitioner degree came from Chamberlain University. She is a well-published individual, including contributions to the Association of Nephrology Nurses Association core curriculum and also the contemporary nephrology nursing textbooks. Currently, she's a senior manager for medical education with CVS Healthcare, and she's also, more importantly for us, the past president of the American Nephrology Nurses Association. Today, Dr. Pryor is going to speak to us about patient navigation and shared decision-making. Dr. Pryor, thank you very much.
Thank you, thank you. Good morning, good afternoon. I am just so impressed with this meeting that we are having. And again, I was COGIC at one time, but I know I give all praise and honor to God that I am here. And I know my purpose for being here is just what I'm doing, nephrology nursing. I just want to say another scripture. Bishop, you stole my scripture, 1 John. I was going to say that, but that's okay. My scripture is, my people perish for lack of knowledge. And so what I'm going to be presenting, yes, thank you. What I'm going to be presenting is probably just a little bit of what Dr. Hall had already presented. So the repetition should be helpful for you. I also have slides, right? So navigation and decision making. I think in our current healthcare system, if you will, navigating that healthcare system is particularly hard. And chronic kidney disease is a very complex, I think it's a little more complex in terms of navigating all of the different parts and pieces that move throughout that system. So I'm just going to, again, repeat some of the things that you've just heard and hopefully give you a few little nuggets that you can also just use to help you or family members navigate through. Next slide, please. So some of the objectives again. Kidney function, I'm just going to review again. Some of the signs and symptoms we talked about already. Some of the options that you have when or if your kidney disease progresses to that end stage state. Some things I want you to think about in terms of care coordination, and then in just a brief summary. Next slide. So what a kidney does, we already talked about that. All of these things the kidney has control of. Your water, how much fluid, it's basically your filter, right? And the heart, I just sometimes with my cardiologist, they say the heart is the most important organ. I say the kidney, right? The heart, the heart gives 25% of actually its power comes to the kidney. So I think the heart thinks the kidney is pretty special as well. Bones, the kidney actually helps to maintain some of that bone health that you have. Acid-base balance, we talked about that. Acid versus alkaline. So the kidney basically is just responsible for having an equilibrium, providing an equilibrium in your body for life. Working 24/7, right? And this filter never stops. Next slide. So these are just a few of the signs and symptoms indicating you may have kidney disease. If you look at these signs and symptoms, what do you see? They're kind of vague, right? These can be anything. And we talked about, it's a silent killer. The number 1 and number 2 causes of chronic kidney disease is diabetes and then hypertension. Used to be reverse, probably about 20 years ago when I started, but now diabetes is the number 1 cause. Next slide. So what now? Next slide. Again, we'll just review very quickly the stages of chronic kidney disease. And you can see stages 1 and 2, you have up to almost 90% of your kidney function. So your kidneys are filtering well, pretty much, you're stable. You want to make sure, though, that you have an annual test, and there are 2 very simple tests that you can do, the EGFR that Dr. Hall mentioned, as well as a urine test. And they can test that urine to see if you're spilling any protein in the urine. Stages 3A and 3B, anywhere from about 30 up to about 60%. And this, full transparency, I was chronic kidney stage 3 probably about maybe a year ago. And I didn't know it. I'm just walking around. I'm a nephrology nurse, good gracious, right? So I went to my primary care, and she told me at that time, it was still race-based algorithm, but she said my EGFR was about 59 or something like that. So I was a little scared. So I got, my health, I changed my diet. I kind of backslid a little bit, but I'm gonna get back on it. But so this is a stage 3A and stage 3B. You want to pay particular attention to, because there are the drugs that are out. You can change your diet, exercise. If you're a smoker, stop smoking. And these things can help to prevent or delay that progression of chronic kidney disease to stage 4. Once you get to stage 4, so now you're dipping below that 30 and you're right at that 15. This is where the preparation kind of starts. The doctor starts to call, or should start to call you in and say, hey, you're progressing. We need to start thinking about your options for renal replacement. And then again, once you get to 15 and below, you are deemed end-stage kidney disease. Next slide. So I talked about awareness and care coordination. So complex, so many different doctors, specialists that you have to come in contact with. And not only that, you go from you're a chronic kidney disease patient or your family member, you see your primary care provider. And the healthcare system in terms of providers, we're taxed. We have to see, the physicians have to see a lot of patients. And so my mother, for instance, I'll give you an example. She went to the doctor probably about 6 months ago or something. She said, oh, I went to the doctor. My blood pressure's fine. I said, Mom, how's your kidneys? What's your EGFR? Because she's hypertensive. He said, it's fine. I said, what does that mean, Mom? I need a number. And so when the doctor kind of tells you, Dr. Hall said, you want a number. You want a number, and you want to be able to go in there and ask those questions. So your primary care provider at a certain point will say, okay, I need to refer you now to a nephrologist just to kind of either help slow that progression, or it's time to start planning for renal replacement therapy. And in the box, you see yourself in the middle, which is where you should be. All of these healthcare providers that are around should be at your service. Social services, a dietitian, pharmacists, very important. Get close to your pharmacist, okay? They know a lot about what meds might be kind of interacting. Some meds you may not particularly need at a certain time, and they will consult, again, I guess, with the provider that orders those. Advanced practice nurses, your NPs, you go into the physician or your provider's office, and you may not see your provider physician, but you'll see a nurse practitioner. Dietitian, pharmacist, and then a diabetes educator. We have a lot of how many in here diagnosed with diabetes, hypertension? Okay, all right. And again, it's the silent killer, so you may not particularly know. You're walking around and you think you're okay, your hemoglobin A1C is now 6. So you're pre-diabetic, okay? Early identification and risk factors are what I want to that's the point that I want to bring home. Our risk factors, Dr. Hall just kind of talked about that: ethics, gender, diabetes, hypertension. Those are some really big risk factors that we want to be careful and pay attention. Your blood sugar, you want to keep controlled. Your blood pressure, you want to keep controlled. Medications, there are a number of new medications that are there that are kidney protective as well as heart protective. So that the sooner that your physician knows about these things, they can get you on the path to maybe start to take some of those medications that can protect that kidney and help you not to progress or to prevent progression to end stage. Diet changes. That's all I'm gonna say. Christmas is coming up. Thanksgiving was just here. There are some changes that we can make, and slight changes, right? So everything in moderation. I'm not saying you have to give up the collard greens like the whole thing, right? But just in moderation. And then exercise. How many of you exercise every day? And exercise doesn't have to mean going to the gym. You can maybe just take a walk every day, maybe 5-10 minutes, and start to do that. That helps, okay? Next slide, please. So this slide just kind of goes through some of the choices. Once you are given a diagnosis of end-stage kidney disease, you have choices, you have options. If you discover it and you identify it early on, you have a chance to plan what option of renal replacement therapy would be best for you. It starts with conservative management, and that was just a poor choice. That was just one of the ways that the slides came up. But hemodialysis, which involves blood, you can do that in a center or you can do it at home. Peritoneal dialysis involves no blood. God, in His wisdom, has already provided us with a filter in our abdomen where we can do dialysis in the peritoneum. Doesn't require you getting an access, a vascular access. Kidney transplant. You can get a transplant preemptively, so you don't have to technically be at, I think, end-stage renal disease, or if there is an algorithm that is showing that you're headed in that direction, you can start planning for a kidney transplant before you even have to go on dialysis. And then conservative management. That's your option too. If you get to a place where you say, you know what, I'm good. I don't really want dialysis. There is an option, and there are providers that can help you to manage your chronic kidney disease conservatively without dialysis, maybe without a transplant. Next slide. So chronic kidney disease actually it goes across the spectrum of life. We can see some patients. I used to work in New Jersey, St. Joseph's Hospital in New Jersey, and we had children that had kidney issues. And so all the way through to the end of life. The life plan, this life plan is in particular is referring to your access, how you would be able to receive a dialysis treatment. Next slide. So these are the different types of dialysis accesses that you may need. For peritoneal dialysis, like I said, there is a tube that is placed in the belly, and it goes into the abdomen, and that is how you would be connected to the machine that would perform peritoneal dialysis. Peritoneal dialysis, I can describe it maybe as a gentler dialysis and more like your regular kidney, 24/7, right? So you're doing this treatment every day, 7 days a week, okay? For hemodialysis, there are three-ish types of accesses. The first one is called a fistula, and the surgeon would sew an artery and a vein together. So that's your own native to you access, all right? And it would produce a fistula, basically a vessel, and you exercise that vessel, and it would accommodate, you would have to have needles used with that access for hemodialysis, right? Because we need access to the blood. The second one is a graft. The graft is similar to the fistula, except they use a tube sewn to one side of the artery and the other side to the vein. And we would basically access the tube that's sewn to either side, okay? And then lastly, there is a catheter that can be placed in the chest. We don't like catheters. I'm just gonna say that. That's the least like access that we have. It's more prone to infection, and the tip of that catheter is directly in your heart. So if you get an infection, not so good, okay? Next slide. And then there's kidney transplant, and this is kind of what that looks like. They will not remove your kidneys. They just kind of insert the good kidney that you have. And again, you can be preemptive. You can get on that list preemptively if you know. Next slide. I'm going to touch on this just a second because we know this, right? Structural iniquities, it impacts our end-stage kidney disease patients and has been for years. Systematic differences in the opportunities that groups have. And so we are now determining that social determinants of health has a greater impact on your health, where you live, work, eat, play, right? Worship, and die, has a 80% impact versus your health care, which is about 20%. Next slide, please. So all of these things, social determinants of health, impact not just end-stage kidney disease, but our health in general. Our employment, the health system, where you live, like I said, transportation, right? If you can't get to the doctor is in another town, and you don't have transportation, that's a problem. Community resources. We talked about diet and nutrition. If you don't have a grocery store in your neighborhood, how are you going to get the good food that you need? Okay, next slide. So this is an example, I guess, or just a little write-up about what Jasmine was talking about. Prior to 2021, that glomerular filtration rate was race-based. And so when you look at your lab work, I don't know if any of you remember seeing that, but it would say EGFR, and then it would say underneath that, EGFR if you're Black. And there was a big difference. So we now, because of legislation, and I just want to say, just for the record, it is about policy, okay? And so it's very important that we advocate for these policies that are going to be more protective for us. But the EGFR, these two organizations, the National Kidney Foundation and the American Society of Nephrology, recommended that race-based EGFR be taken out. And they are now calculating based on a different equation and different numbers, okay? So yeah, we're making some progress. Next slide. This also is something else that I just wanted to bring up. In order for us to kind of ensure that algorithms are fair and equal and equitable, we need to have the data. And so recently, there are ICD-9 codes, and that's what you're billing when you go to the hospital, when they have to bill you for every diagnosis and things. We are now collecting the data for social determinants of health. And that's going to be important in determining, how we're starting to provide some of this algorithm in these treatments. Next slide. So in summary, I just want to say awareness and education. Make sure that you're aware. And even if it's not you, a family member or a church member, just mention these things to them. Early identification is super, super important because time is what? Time is kidney, okay? Early intervention, if you know earlier, if you know better, you do better. The referral to your kidney doctor or the kidney team is, again, super important, all right? They can help you to either slow that progression or to prevent you from progressing to chronic kidney disease. Know and discuss your options. You do have options. Ask about those options. Just because you go into the office and they say you now have to have dialysis or some type of renal replacement therapy, ask them, can I do it at home? Is that an option? Do I have to do it at all? Is that an option? Okay? Prepare and plan. If you know better, you have the option to plan what that looks like for you and your family, because it's not just you, it's your family as well, right? Commit to the plan and commit to identifying these things early. And then once you identify, ask the questions, write your questions down. When you go to the doctor, he'll help you to come up with a plan. All of those healthcare providers that was in that circle, they're all available to you once you are diagnosed, and they can help you come up with a plan. And then 1 John 3, 1 and 2. I pray that you would prosper and be in good health, even as your soul prospers. Beloved, I wish above all things that thou mayest prosper and be in health, even as thy soul prospereth. 3 John. Thank you.
You didn't really think you were going to get away with quoting without it being accurate. So it is interesting, if you go back and look into the Bible, you'll find that there's actually in Psalms a reference to examine the kidneys, because in the old Hebrew text, actually the kidneys actually are the inner core or the self of humans before anybody thought about being the heart. So kidneys actually do have a significant function there. I want to point out too, next week we're going to have part 2 of our discussion. Just want to say, an old Episcopalian can also bring something too. See? Next week, we're going to have part 2 of our discussion, and we're going to get in a little bit about treatment, but also a lot about policy. So if you're here today, I hope that you'll be able to join us then, because that should be a very interesting discussion. We heard Dr. Pryor and also Dr. Hall both commented a bit about dietary modifications that one has to make when you have kidney disease. And we're going to hear a little bit more about that from Ms. Deja Ivy, who is going to talk to us about diet and nutrition for adults living with chronic kidney disease. Ms. Ivy obtained her bachelor's degree in dietetics from Life University. She got a master's degree in health sciences and nutrition from Georgia State University. And she's also currently as you still work with Fresenius as far as the clinical? Yeah, Fresenius as a clinical dietitian and medical care for them. So again, diet and nutrition for adults living with chronic kidney disease, Ms. Deja Ivy. Thank you, ma'am.
Hi, everyone. It's wonderful to be with you today. I do have some slides. But yeah, I'll start off by introducing myself. My name is Deja Ivy. I am a dietitian, and I practice research as well as in clinical. And I have about 50 patients that I work with on dialysis in Atlanta, Georgia. So I'm very, very excited to be with you all today. And we're going to talk a little bit about eating to protect your kidneys, whether you have CKD or not. We'll go to the next slide. Oh, yeah. So a little bit about me. As Dr. Tuxton already mentioned, I have my bachelor's from Life University, small university, Marietta, Georgia, and my master's from Georgia State. I completed my clinical training first at Grady Hospital in Atlanta. So lots of gunshot wounds and car accidents, and that's when I first got really, really interested in kidneys and how they perform. I went on to do some more training at Piedmont Hospital, where I learned a lot about hypertension and diabetes, as well as pediatric diabetes at CHOA. And now I practice at Fresenius, like I mentioned, with my dialysis patients. Next slide. Okay, so by a show of hand, who here has heard conflicting ideas or advice about kidney disease and what to eat? Okay, I got a few hands. If you've heard conflicting advice, you are correct. Dr. Hall previewed this a little bit, and we can go to the next slide. There are kind of 2 CKD diets. We have our diet before we get on dialysis, and then a diet after dialysis. So if you've been told by your physician that you have chronic kidney disease, they'll let you know what stage you're at. And as we've discussed, it's stages 1 through 5. And around stages 3 and 4, hopefully they're recommending that you start to make some dietary changes, if not earlier. So one of the things that they'll ask you to do is to reduce your protein intake, because your kidneys are responsible for helping to break that down. And as Dr. Hall mentioned, as the kidneys continue to be damaged, you'll start to have some issues with your fluids. So you'll start to retain more fluid, and at that point, you'll want to cut back on it. And then they'll always recommend low sodium. Once you've reached dialysis and you're closer to stage 5, your diet will start to change, and hopefully you'll be paired with someone like myself who's a renal dietitian. At that point, when you're on dialysis, especially hemodialysis, there's a lot of blood being filtered by a machine, and it starts to take out some of the nutrients and protein in your blood. And so we go from recommending a low protein diet when your kidneys are damaged to now recommending a high protein diet. We also recommend that you guys have if you're on dialysis, you have very limited fluid, because oftentimes people who are on dialysis are auric, meaning they no longer produce urine. So you're thinking, where does it go? When you go to dialysis, they pull off fluid, but we have to limit you all. So normally that looks about 32 ounces per day, which is about 4 cups. It's very, very limited. And so one of the things I do is help people strategize on how to stay within that limit, but not be dehydrated. By show of hands, just so I know who I'm talking to, who here is on dialysis? Okay, a couple people. And if you don't mind sharing with me, who here has been diagnosed with CKD? So a couple people. Okay, good to know. Thank you, guys. Additionally, once you get on dialysis, there are some other factors we have to consider. Also some things that Dr. Hall mentioned about your electrolytes. So that includes sodium, potassium, and phosphorus. And we're going to talk about those three a lot today. Next slide. So let's start with the positives. As dietitians, we get a lot of slack about being the food police and taking away all of your favorite foods. So I want to start off talking about what you can eat on dialysis. Beginning with potassium. So potassium is often found in fruits and vegetables, and having elevated or decreased potassium in your body can actually lead to heart issues. So if you have any differences in the normal function when it comes to potassium, it actually could lead to a heart attack because it's a muscle, and potassium contributes to that muscle contracting. So some low potassium fruits or vegetables that you can have include things like apples, berries, blueberries, strawberries, peaches, pears, tangerines, watermelon, lemon, and lime. And then vegetables, there's actually a very, very long list. I pulled this directly from Fresenius's nutrition website, which you can access. Some of the things that are included are asparagus, bean sprouts, broccoli, cherry tomatoes, cauliflower, kale, leeks, lettuce. You have a wide variety. Next slide, please. What becomes complicated is when we start talking about our food products. So by product, I mean anything that you don't see growing in nature. It's been produced, it's been processed, and then given to you as a food. So some of those things that you can eat, even if you're on dialysis, include things that are kind of fruity or sugary, because phosphorus is very present in chocolate. So we ask our patients not to eat that, not to indulge in that. So some of those things might be fruit pie, Jell-O or gelatin, hard candies, jelly beans, marshmallows, popsicles. And then for more savory snack types, really you want to make sure that it's low sodium. But some of those things include bagels, croissants, graham crackers, muffins, rice cakes, and then unsalted pretzels, popcorn, crackers. So a few tips on how to guide yourself through snacking when on dialysis. One, I always say buy unsalted or low sodium. Two, you want to think more of fruit or sugary dessert items over chocolate. And three, you want to remember your fluids. So again, our dialysis patients tend to be auric. They're not making any urine, so we want to watch that. So anything that melts in your mouth and becomes liquid at room temperature, that's something that you want to monitor. So that looks like Jell-O or gelatin, popsicles, but also things like watermelon, which is something that you can have when you're on dialysis, but you want to have one serving. Now this is going to be interesting. How much watermelon do you all think is one serving? You said the whole watermelon, definitely not that. We're not going to go with that one. Any other ideas about what one serving of watermelon might look like? One slice, y'all. Just one. And as it was already mentioned, diabetes is like the most common cause for kidney disease. So we really have to watch our sweets, including our fruits, and making sure that we're eating the proper amounts. Other examples of a serving of fruit would be a small apple, the size of a woman's fist. And I know that we're now in the age of GMO, so usually our apples look like grapefruits. So just keeping that in mind, cutting in half, things like that. All right, next slide. Okay, what foods are good for my kidney health? Now this applies to everybody. What can we do to protect and keep our kidneys healthy? Next slide. Okay, so starting with low potassium fruits and vegetables. So of course they're going to be natural, they're going to be low in sodium, and some of the general benefits of fruits and vegetables include fiber, which helps us to excrete and eliminate toxins. They have antioxidants. If you ever heard of anything about free radicals and them attacking our cells and eating chocolate or wine to stave that off, that's what they're talking about, those antioxidants. They're also natural laxatives, and they're rich with vitamins and minerals, which when we think about our foods, unless they've been fortified or supplemented, really a lot of the foods we eat don't have vitamins and minerals. So they're essential for our diet. Other things to consider are inflammation. So if you're somebody that has any kind of swelling, your ankles, your hands, you are experiencing inflammation and probably some fluid retention as well. So we really want to eat anti-inflammatory foods. This looks like healthy fats, nuts, seeds, berries, and fatty fish. So some examples of that are strawberries, blueberries, blackberries, raspberries, walnuts, flax seeds, coconut and avocado oils, salmon, trout, mackerel. And then lastly, we want to have adequate water. And I use the word adequate intentionally because we know that our dialysis patients need to restrict that. So we want to remember that water is going to help flush out our kidneys. So if you're somebody that's limited to 4 cups a day for all of your fluids, I highly recommend that 3 of those cups are water. Okay, let's go to the next slide. What should I avoid? Okay, here comes the hard part, but I promise you guys we'll talk about ways to make it easier. I want us to first remember that all the things we've already talked about, foods that are safe for our kidneys, foods that help our kidneys, those should probably be the foundation of our diet. And then we'll add in the fun stuff. Let's go to the next slide. So phosphorus. Phosphorus is a major concern for people who are on dialysis because if you don't excrete phosphorus, it can build up in your body and cause calcification. This can be calcification anywhere. It could look like hard deposits in your fingers. It could be a calcification in your heart. And it can make you ineligible for kidney transplant. So I really, really, really work with my patients on managing their phosphorus. Additionally, if you're on dialysis, you probably have also heard of something called a phosphorus binder, something you should be taking with every meal. That's something that your physician is going to prescribe for you, and we'll kind of circle back to that later on with some tips. But phosphorus is mostly present in foods that are processed. And inorganic phosphorus, phosphorus that's found in foods that are not natural, is absorbed for about 90%. So they're highly, highly absorbable. Versus if you have something more natural, like beans are naturally high in phosphorus, you're only absorbing about 20 to 40%. So a lot less. So some of those foods include meat products. And our lean meats are a little bit safer. So this mostly looks like red meat and pork. Other things that are really high in phosphorus additives include dairy products like ice creams and fat spreads. Your product snacks are usually high in phosphorus, and then other things like Coca-Cola and dark cola products. You'll see with the macaroni and cheese, the Kraft mac and cheese food label, that phosphorus is listed in the ingredients. That is absolutely something that you want to be looking at if you're on dialysis. Turning that label around and seeing what's present in there and looking for anything that has phos in it, P-H-O-S. Next slide. Okay, foods to avoid. So I'll say moderate. One of the things we want to eat in moderation are our quick and convenience foods. These are fried foods, fast foods, anything not fresh. You should consider processed. These are things in cans, boxes, and containers. So oftentimes I like to tell my patients, imagine a grocery store. Normally if you're at a grocery store, that perimeter of the grocery store has all your fresh fruits and vegetables, your lean meat items, maybe some of your healthier frozen products like frozen fruits and vegetables. Those are all really great. And then inside the aisles, we have all of our processed foods, which is the majority of the store. Okay, so next, red meats. Red meats are something that we're going to want to moderate, although protein is really important because, again, as we're filtering that blood and those larger protein particles are being pulled out, we want to replace them, but we want that to be the right kind of protein. So processed red meat and pork often have high phosphorus preservatives, and this is for a couple of reasons. One is for moisture and taste, but also for coloring. So things like hot dogs, deli meats, and sandwich meats are also really high in those, and you want to try to avoid them as much as possible. And lastly, beverages. So beer is high in phosphorus. I don't want to take anybody's fun away, so I would say talk to your physician about whether or not you can have wine or some other type of alcohol if you're wanting to indulge in that. Dairy products, like we talked about before, tend to be high in phosphorus, as well as dark colas. So those are the kinds of things that you want to cut back on. Next slide. Okay, some helpful tips. Next slide. So of course, we want to read our nutrition label. Unless we're talking about a natural food, something you would see growing in a garden, we really don't know what's in that food. So we want to educate ourselves and see what's in there. Again, we want to look for anything with the word phos in it. That means that phosphorus is present in that product. So if you'll see in the image on the bottom, those are a couple of examples of how you would find them or what that might look like. Another thing you want to do after reading the nutrition label is looking at the serving size, which would be at the very top of how many servings are present in a package or container. And you want to stick to the serving size. You want to be really aware of how much potassium or phosphorus you're getting in one sitting. Next, you want to remember to take your binder as prescribed. Again, you want to talk to your physician or your kidney doctor, your nephrologist, about what the prescription for your phosphorus binder is and how often you should be taking it. And your renal dietitian should be reviewing your labs monthly on your potassium and phosphorus and can guide you on whether or not you're meeting those numbers. And lastly, you want to opt for natural, kidney-friendly foods. Processed and fast foods, they just aren't giving a lot to us. So we can still enjoy them, but we just want to know that they're not great for our health. And we want to stick with the perimeter of the grocery store. And we'll go to the next slide. I have my contact information on there if you guys would like that. I also have a private practice where I meet with people and I help them figure out how to make nutrition work for them. You can go to that link or email me if you're interested. And I thank you for you guys' time.
Thank you very much, Ms. Ivy. And again, I remind everyone that we will be taking questions after the end of our next speaker. I'd like to next bring up Ms. Shamika Simon. She is a community health educator. She received her AA degree from the City Colleges of Chicago and her BA in magazine journalism from Columbia College of Chicago. She subsequently obtained certification in community health work from the Malcolm X College, as well as a health education certificate from the Sinai Urban Health Institute. Ms. Simon will be speaking to us today about addressing health-related social and supportive needs, wellness assistance, and resources. Ms. Simon.
Hello, everyone. Nice to meet you. Great to be here today. So today we'll be talking about, I'm Shamika Simon, community health educator, and also I'm trained as a community health worker. So I serve as a liaison between your physician and also yourself. So patients that come in that have issues with understanding medication or education when it comes to their health issues, or even just getting access to housing, to food, to just all types of care, I'm able to assist them with that. So the social determinants of health are the non-medical factors that influence health outcomes. These conditions shape the environments where people are born, grow, live, work, and age. So the nurse Lillian actually spoke about that. So each of these factors is interconnected and shapes an individual or community's overall well-being. So those things will be economics, education, healthcare access, neighborhood where you live, and also social and community contacts. So finding community resources. So it's important when you're looking for community resources to start with your local networks, to use online tools, to contact advocacy groups, and to connect with your healthcare providers. So I have a list of actually resources for the Philadelphia area, if they can get pulled up. Okay, so local kidney health resources. So the National Kidney Foundation and the Penn Kidney Medicine, as well as Gift of Life Family House. So it shows the address and the number, as well as the link. So I work with the church staff to see if they can provide this information for everyone. And then there's general health and supportive services. So like the food assistance, there's Philabundance, Food Bank of South Jersey mobile pantries, prescription assistant programs, transportation for medical appointments, and also the contact information with the email. And then there's also free clinic access, and then food bank, community support programs. So this is a continuation of actually community support programs. So here are some patient assistance programs and organizations that help with medication costs in Pennsylvania, specifically in the Philadelphia area. So we have Patient Advocate Foundation's copay relief program and their information, as well as the Pennsylvania drug card, and then Appraise. And then there's an organization called PACE, Pharmaceutical Assistant Contract for the Elderly. Of course, we have Medicaid, the RX Helper, and then also the 211 helpline. Okay. And then we have websites like Bertha, Needy Meds, and findhelp.org provide a searchable database for services tailored in your zip code. So does everyone have a cell phone here? Okay, so if you pull out your cell phone, I would like everyone to go to this website. It's called findhelp.org. If you look up at the screen and you're having an issue with going to the website, you can just look at the screen. Sure, so it's findhelp.org. So you can search it through Google or your browser, and it should come up. The screen is actually going to look exactly like this. So basically what this is you're able to find free or reduced cost resources related to food, housing, and basically those social determinants of health that we actually just discussed. So when the zip code is entered, which is this zip code 19120, this is what comes up if everyone could look at the screen. Okay. So you'll be able to see like the sections and categories where it says like food, housing, and you have subcategories where you actually can click on the subcategory and you're able to find the different resources like within your area for what you're looking for, whether that be food, medicine, clothing, housing. This website is able to provide those services for you. So the importance of finding community resources like within your area, you want to start within your local networks. You also want to use online tools, connect with advocacy groups. I believe church is like a great place to start to figure out and find out what resources you have within your community. And also tapping into those healthcare providers like we discussed earlier. And the process of navigating resources can be a hard task. So it's important to get in contact with your care team. And a lot of times I'll work within a care team for patients as well too, to just be able to be that liaison that is able to keep the patient comfortable if they're not able to actually understand something that the doctor may said or understand something that the social worker may said as well too. And another thing is during the navigation process, when you're looking for community health resources, you want to be prepared with your documentation. You want to understand the criteria for actually seeking these community health resources. You want to ask for help. It's very important to ask for help. No question is a stupid question or a dumb question. And when we know, we grow. I like to say that. Most organizations have staff trained to assist you. So when you ask questions, you're able to find out and figure out who are the staff that's there to assist you so that you can get the information that you need related to whatever chronic disease or medical condition that you actually may have. And then it's important to actually follow up and leverage your peer support. So joining like online groups where others share tips on navigating resources is like really good. And I even suggest everyone getting to know like your family's health history. You know, when you're in a grocery store with a family member, when you're at the family dinner table, when you're just out at a doctor's office with family members, like I feel like in the Black and brown community, we need to start talking about our health more so that we know the health conditions that we have in our family and we can adjust them accordingly. So thank you all for your time.
Thank you very much, Ms. Simon. I appreciate that. I'd like to bring the speakers up here if we can, so we can have begin our panel discussion. And Mr. Felt, I must admit, you guys practice what you preach. The sister who's tried to make sure that we're staying healthy by wiping down this, I really appreciate that. And also I want to thank you. Not only is this a wonderful edifice that you have here, but also your audio visual people. They've just done a great job. Can we give them a hand? Come on down. Now, like I said, we're going to start off with, Daisy, bring another chair for us. We're going to start off the question. I had promised that you would be the first. Why don't you stand up for me if you can? Too bad. Now you raised your hand. That'll teach you. Okay.
I have a question. You said about it's not hereditary in the family. It's hereditary in my family. My mother died from it. My brother died from it. My grandmother died from it. I've been having kidney disease for 10 years. My sister have it. My other brother have it. So it is hereditary.
So she is a plant because for those of you who don't know, Dr. Hall's research happens to be around genetics and kidney disease. So Dr. Hall, why don't we get you to start off by answering the question? Point being, she has a long genetic or family history of this. So how would you, let's pass the microphone. We have another microphone down there. We have two? Yeah. I'll take this one. We're going to defeat you, unfortunately, on this one. Go ahead, Dr. Hall, please. And if you have a question, please raise your hand. Okay, I'll come over to you.
So, yes, genetic kidney disease is something that we're gaining a greater and greater appreciation for. It used to just be a category of disease we would consider rare disease. So it would be in families, but at a very low frequency. Most of what we understood came from studies of kind of majority populations and their experience with it. My work specifically focuses on looking at rare disease in African American families. But there is a more common genetic kidney disease that relates to a protein that is sort of miscoded, if you will. It's mutated. It's called apolipoprotein 1 or ApoL1. I'm not sure. Has anyone heard of that? Just raise your hand if you have. Okay, so this is a great opportunity to say a few words about it. Apolipoprotein 1 is something that, and mutations in that protein are things that we came to understand in 2010, 11-ish, based on the work of an investigator from Harvard. And the study that he did, he was really looking to try and figure out why is it that African Americans or people that kind of are of recent African ancestry, why are they so much more burdened by kidney disease than other ethnic groups? So he assembled a group of patients that kind of fit the criteria for what he was interested in studying, and he identified this particular gene, apolipoprotein 1, and he found some really high signals for connecting mutations in that particular gene and the incidence of kidney disease in those people. So that was a really sort of groundbreaking finding, because up until that point, we clearly knew there was a pattern that African Americans were susceptible, but we didn't necessarily know why, other than to lay name the usual suspects like diabetes and hypertension. But there was something else, we couldn't figure it out, and this seemed to be the first indication.
Jasmine, let me ask this. So Jasmine, let's go back to another issue. Yes, he's pointed out there is something chromosomally related, yep. But we also find that people who tend to live in similar conditions tend to come down with very similar diseases. You touched upon it, and also Dr. Pryor touched upon it. Social economic factors or political determinants of health also can increase or been associated with certain things given kidney disease. So now we have a genetic thing. Which do you think? Is it working together, or we got two different issues that are seen to be directing why we're seeing higher incidence in African Americans?
So it's never either or, it's both. right? So one thing that I will say whenever it comes to chronic kidney disease, no patient is the same. Like everyone's journey is a little bit different. So like speaking to your question, for me, it wasn't hereditary, right? I'm the only person in my family who has had to deal with this disease. So you have patients who it is genetic, right? And you have others that it isn't. So there's this big debate that's going on in the healthcare field right now, especially whenever we talk about equity. How can we eliminate the use of race while still trying to understand why Black and brown populations are disproportionately disadvantaged by this disease, right? And so we have to look at the healthcare access in that area, right? So for instance, a great example here in Philadelphia, the closing down of Hahnemann Hospital, right, which was a medical center for a lot of different people in North Philly, and now they have to go to Temple Hospital or they have to go to Jefferson. Then we also have to talk about insurance, right? Who actually has access to insurance that will allow you, right, to ask for specific testing and things of that nature, or if they'll even approve it. What's your income like, right? Because if insurance isn't going to approve it, can you pay for it out of pocket? Do you live in a food desert, which basically means do you have access to the quality foods that you need, like Deja was talking about? Are you just eating from fast food restaurants, poppy stores, things of that nature? Or do you have access to like fresh foods? And even if you do, what is the quality of those foods, right? Like what are they putting in like that food in the supermarket? So there's so many, and also, right, even like the historical barriers as well. How has your area been affected, right, by different things, whether it is medical related, policy related, right? Some even link it to like police presence in different areas. What is your stress level, right? Right? So there are so many other social determinants and barriers that we can look at where Black people are affected by more than other populations. And so that is the debate within the healthcare field right now of how can we erase race, right? And actually look at these social barriers, but that's gonna mean that we have to have some very difficult conversations.
All right, we got another question over here, please, ma'am. Go ahead.
Okay. I'd like to know what is creatinine? And another thing I'm concerned about is people who are taking blood pressure medicine. A lot of medications we take affect our kidneys, which cause kidney function to go down. So if someone is taking a medication which is affecting their kidneys and the function go down, could there be a medicine that someone could take while they're taking that medication to protect their kidneys? A lot of people stand back from taking blood pressure medicine because it's been spread around and it affects the kidneys.
So Dr. Pryor, why don't we go ahead? First off, what is creatinine, number one, and then number two, let's go. Dr. Pryor, I want you to start off with this one. Yeah, that's right. We're going to make you start off on the first one. Okay. So let's go to that. Then let's talk about some of the medications that we're taking and what impact that could have on our renal function. Do we have to be careful? I guess it's almost getting into the thing of polypharmacy. So many of us, especially as we get older, we get multiple medications, and then we get side effect, and then we got to take a medication for that. So address these issues for me.
Correct. So creatinine basically is the breakdown of the muscle, which is a function of what the kidney does. And it comes through as creatinine, right? So it's the filtering and the breakdown of the muscle, and that filters through the kidney. All the poisons and the toxins and all of that kind of stuff is broken down, and that's what the creatinine is, correct? Mostly.
Oh, you wimping out on us. Come on, keep going.
And with the medications, there are medications now that are kidney protective as well as heart protective. The medications that you take, I think, and I'm not a provider, but some medications work well with one person and they may not work well with another person. And so that's why it's important for you, if you're taking blood pressure medication and your blood pressure is still 150/90, and you're taking this medication, that blood pressure medication is not working. So you go back to your physician and say, this is not working. What can we do? Do we have to switch medications? Because there are a number of different combinations, if you will, of those medications that you can take. And then What's your diet look like? Are you exercising? Are you a smoker? All of that contributes to your blood pressure control as well.
Well, let me ask Dr. Hall, so if you would add to that about the blood pressure medication, but also something which a lot of us take medications over the counter, and we naturally assume that because it's over the counter, it's not going to harm us. Specifically referring to patients taking aspirin or some of the other, like Aleve, naproxen, or even Motrin medications. Could you make a comment about that and also about the hypertensive medications?
Yeah, so hypertension or medications that regulate blood pressure are generally, depending on the severity of your blood pressure sort of deviation, you're more likely than not going to have to take a combination. So more than one agent. Certainly if your blood pressure is severe, you'll have to do that. The risk is obviously that they are powerful medications. They can lower blood pressure. And when blood pressure is lower, that affects kidney performance. So it's one of those things where you have to be in regular consultation with your primary care doctor or nephrologist to get that balance right for you. There are recommendations that we follow, but not all those recommendations are right for every person. And so that's why we have to work with them to figure out which combinations work well to keep you in the range where it's safe for you to be on them, but at the same time, it's not, or it's accomplishing the goal that we want, but then it's also safe for you to take them. As it relates to over-the-counter medications, yes, you can go into any pharmacy and get medications for headache, muscle pains, and so on. Where that becomes an issue that we have to manage are things in the class of non-steroidal anti-inflammatories or NSAIDs. Things like Aleve, ibuprofen, Goody powder, BC powder. Those are some blockbuster medications as it relates to kidney function, particularly when your kidney function is already compromised to a degree. So you have to be really careful, one, what you do to address your pain without the consultation of a healthcare physician, but also what medications your doctor, you and your doctor have discussed are safe for you at your particular level of kidney.
Thank you very much. We have another question over here, please.
Sure. So I have a few questions. I was just wondering, is there any science on reversing kidney disease or even using some kind of natural cure for treatment or anything like that? Also wanted to know the effects of COVID on the kidneys. Was it harder to overcome COVID if you had a kidney problem, or were you able to maybe getting it easier if you had kidney problems? And the last thing, is there any realism about harvesting kidneys? We've heard like some people even in the prisons waking up to having kidneys missing. So if you can, any of those things that you can help.
Okay, thank you very much. So I think the first thing we're going to talk about, managing versus slowing down. I think you made a comment about that in the presentation. Then what can you do to reverse things? And then, but let's take the last one, and then we can talk about COVID, but let's take the last one, please. Harvesting of organs from people unwittingly. Is there anything to that? Let's get to, no, Ms. Simon, why don't you make a comment about that? Because this is sometimes we're afraid of. Sometimes you hear people say, I don't want to sign the donor card because if I do, they're going to come snatch my kidneys. But that's not real. Is it?
No.
I'll tell you what, as a surgeon, I will answer that question.
Yeah,
No, it doesn't happen now. It doesn't happen. There is a big fear, particularly in our community, how we've been treated for many things. But in terms of actually harvesting organs, going in and taking out, there was a scare. People were talking about that. To my knowledge, in my experience, and walking around, no, that is not taking place here in the States. Now, you remember when Franco was dying, there was a question about him. But no, that's not really happening. So let's dispel that.
And I was also going to say, we have to be mindful in the Black and brown community of where we get our information from and how you have to educate yourself. You know, you can't go based on what you heard. You got to go based on what you know, and we have to continue to educate ourselves. That's why it's important to get in our community and find out what resources and everything we have, because a lot of information that we get pertaining to health is factual. Well, it's not factual. It's actually infactual. It's not factual. So, and we have to really stay committed to like looking into the information that's being fed to us, because a lot of times that can determine your outlook on how you take care of yourself. And when we go into these different facilities and just wherever we go, places where we're actually taking care of our health in our health space, it's like when it comes to our health, we have to be advocates for ourselves.
So we should sign our donor cards when we get our driver's license. It's okay to do that.
It is okay to do that.
Let's talk, when you were talking about having the disease, what things can we slow down? Is there a role for dietary modification that we can at least decrease the manifestations of the disease if we can't stop it dietary-wise?
Absolutely. We talked a lot about what we can eat to help protect, but another great word is preserve your kidneys. So like we mentioned, if you're pre-dialysis, watching how much protein you're taking in, making sure you are drinking enough water if you're not retaining any fluid, exercise, having a healthy weight, and then also complying with your medication so that your kidney disease doesn't get worse, and talking to your physician. So there are some things we can do.
So Dr. Palmer, I don't want to go on dialysis. I don't want to transplant. I don't want to take any medications. Is there anything that's homeopathic that I can take that is going to stop all this stuff from happening so I don't have to take Dr. Pryor first? Yeah, supplement. Yeah, you're Dr. Pryor, right? I'm sorry, did I misunderstand? Dr. Pryor. I said, that's Dr. Hall. Dr. Pryor. Let me reintroduce the panel because they don't know who they are.
Introduce us to ourselves because we don't know.
Go ahead.
But I have heard some homeopathic, not medicines, I won't say, but herbs and those types of things that you can take that are kidney protective. However, just remember, your medicines are made from plants and herbs. So while you may be taking those herbs to protect the kidney, if you're taking medications along with that, it can kind of, have a bad combination, right? And it can be a bad reaction. So your pharmacist would be able to kind of help you with that. I had a woman come in and she was taking a medication. She was getting ready to have a kidney biopsy. And she was taking an herb or some medication, a herb actually. And right before the biopsy, she told me, well, I've been taking this herb for quite some time, and I think it's helping. She was lupus. I mentioned it to the nephrologist. We looked it up, and the herb actually caused bleeding. So if we were to go in and do a biopsy, that would not be a good thing. She could have bled like a lot just from taking this herb. So just be very careful.
Okay. So
if you are.
All right, Dr. Hall. To the COVID point, we knew there were a lot of problems going on with COVID and how the virus would address it or attach itself to the vasculature. So what about the acute? And then now that we're seeing long-term COVID, are we seeing some renal effects here?
So COVID, we're still actually learning about COVID. It's very important to ready ourselves because that's all I'll say. What I will remark on this is what we noticed early in COVID was something very similar to what we saw with HIV back in the 80s. And the reason why is because they're viruses. As it turns out, the way that your body interacts with viruses when they enter your bloodstream, the immune system engages in a program that activates sort of an overwhelming sort of system of clearance. It wants to get viruses out, and it does so in an indiscriminate way. That can have particular effects on the kidney. It's one of the things that I and my colleagues study, and it causes a type of problem with the kidney filter called FSGS, or collapsing glomerulopathy. Don't have to remember that. What it does, though, is a particularly resistant form of kidney disease. It doesn't respond well to treatment. It causes you to lose a lot of protein, and in some instances, it can obligate people to dialysis. So this was something we noticed early in COVID, particularly before some of the treatment regimens became available. It's probably something you won't see now, particularly associated with COVID. But as we are kind of entering another phase and the potential for that type of scenario may go up, just be mindful that your kidney health is something that you really are going to have to monitor, certainly in the next little stretch.
I want a show of hands from Drs. Hall, Dr. Pryor, and Ms. Simon. Are you recommending COVID vaccines for your patients? Raise your hand. Yes or no? Raise your hand. Yes?
Absolutely.
Absolutely. Ma'am, stand up, please. Want to have your question?
All right.
You just you got some fancy hair. I just want you to see it.
So to answer the young lady's question, I am a certified natural health professional. I am a herbalist. I am also a sclerologist and iridologist. So unfortunately, not looking at Wendy, I've helped everybody else with their health, cancer. I got kidney disease. And then I started looking at, okay, what developed this? Well, how did this go from bad to worse? So I started looking at people's diet, and I do emotional therapy. Sometimes your emotions get involved. So the question that she said, can you get alternative support? Absolutely. When I go on the red veins of your eye, I see history. I see what you're eating. I see the parasites. And even myself, they reduce my time because I changed my diet and deal with emotions. So yes, to answer your question, you can get off.
Thank you very much. Ma'am, you had a question.
Hi, how are you? My question was, most of the time when you go to the doctors, their main focus is your heart. So I'm thinking, why do they focus more on your heart in reference to hypertension instead of being concerned about your kidneys? As a young person, I was younger when I had a stroke. Thank God it didn't affect me in any kind of way. I'm still on medication for that, on top of medication for high blood pressure. So with, like you said, with the medications, taking all the medications, and their focus is not on the kidney, the focus is on the heart. I have a cardiologist, I have a primary doctor, but they never told me to go to a doctor.
Sounds like she may need another doctor. Dr. Hall, what do you think?
Well, so I think the way they teach Western medicine is worse first. So in terms of what can cause the most harm if I don't manage it well now, obviously if your heart doesn't pump, that's it. So we focus our physical exam on the things, one, that we can assess with our equipment and our testing, and then we will kind of move on down the list, adding on other elements that we can sort of adapt. But it's not because they don't care, it's not because the kidneys don't matter. It's because, the kidneys don't sound like anything when you put the stethoscope over them. They're just other things that you have that are more sort of risk averse if you ignore them or you miss them. So that's why they get cardiovascular exam gets.
Ms. Simon, I was a bit flippant when I said maybe she ought to see another doctor, but really there's some truth in it. Tell me, what's wrong with this patient going back to her doctor and said, I understand this. Do you think we need to be concerned about my kidneys? Tell me about that empowerment part for the physician, for the patient rather.
When you mentioned hypertension, the first thing I thought about was how are your stress levels? Yeah, so it's like a lot of times we go in and, we have issues with, we may have issues with our different organs or body parts and things, but it can be stress, honestly. It can be a decision that you got to make 2 weeks from today. It could be the fact that you just got a 30-day notice, or someone, your daughter or son or something, just got hurt, or it's more to, our health than just our body parts or our intestines or our heart, our kidney, our lungs. It goes back to those social determinants of health. So the first thing I do when I see a patient, I ask them, how are you feeling? Like really, really, how are you feeling? So yeah.
I will add, of course, if you're concerned, bring it up with your primary health care. Yeah, okay, good. And I thought, but to everybody, if you got a question, ask. You're paying for it. Ask. Yes, sir, stand up for me, please. We'll get you. Yes, I'm sorry.
And I was, again, going to say, if you are seeing a physician or a nurse practitioner or any medical professional and you don't feel like you're being served correctly, you can fire them because you pay them. They're there to service you, so yeah.
We're very sensitive people. We don't want to just be fired. Stand up, please. Yes, sir.
2 questions. One, do doctors swear an oath that food be like medicine, but medicine be like food? Is that true or not?
I think you're probably referring to the Hippocratic Oath. That is something that we all take, some at the beginning of their medical career, some at the end of graduation. Now, you asked me about what it actually means. We can get a different discussion.
Okay, yeah. So, with a plant-based diet work, the reason why I said Eric Adams, who's the mayor of New York right now, he had high blood pressure issues, but he changed his diet, and there's no problem with high blood pressure.
I don't know if Eric Adams was the guy I would use for anything right now. But to answer your question, Ms. Ivy, would you comment to us quickly about dietary, again, this gets into dietary modification. Not necessarily being a proponent of one type of diet or another, but diet is related to health. Food is medicine. That might be one of the things you're alluding to. But yes, make a comment, please.
Yeah, you asked about a plant-based diet. Oh, yes, absolutely. In fact, there's been like a lot of research on a plant-based diet as it pertains to like a renal diet or a kidney diet. And in some ways, it can actually be more helpful because of the products. Going back to, those food additives and about how 90% of them, when, you're talking about, let's say, a meat product or a dairy product, you're absorbing that phosphorus. If you have a plant-based diet, you're only absorbing 20 to 60% of that phosphorus. So they've seen a lot of merit in having a plant-based diet, being on dialysis.
And I think one of the biggest things you really want to watch out for, not only is it being a plant-based or meat, because you look at our diet, anyway, we are omnivores by nature, but looking at the amount of processed food that we're taking in. If you want to look at the real culprit for a lot of the things we're doing, it's the processed food that we're getting into right now. That is a huge, huge problem. Yes, ma'am, stand up, please. And thank you for waiting.
No problem. I'd like to ask the question of what does it mean when a person has been diagnosed diverticulitis? Do they have to start mindful of their kidneys? And if a person has to eat a meal where everything must be gluten-free? Those two questions.
Sure. Diverticulitis is a GI disease, so it doesn't really relate at all to kidney disease. They're two separate things. But if you've been told that you have diverticulitis, I agree with what you said. I think you said something about like low fiber, nuts and seeds can also be an issue. So you'll want to follow that diet, which is totally different than the kidney diet.
And also, there really isn't a great correlation between that and kidney disease with diverticular disease. But again, as what Ms. Ivy was saying, both are dietary related. We're going to take one last question, only because we're running out of time for our program. This doesn't mean we're going to walk away. These folks are still right there, and I encourage you to ask them the questions. I want to make sure that everyone fills out the second part of the, that's right, I'm talking to you, fill out the second part of the survey. So she's trying to hide like she wasn't going to fill it out. Fill out the second part of the survey, if you would. And we're going to do this again next week. And if you have a question that we didn't get to, you can ask it again next week. And tell your friends too, because I hope that this was worthwhile for everybody. And I want to make sure it's okay. So let's get this final question for our panel, and then we're going to turn things over to the deacon.
Hi. My sister has stage 4 kidney disease, and she's had it for the past 3 years. And now her number, it's gotten worse, and her number is 17 the last time. But she's not one who will ask questions or anything. Plus, she lives in Maryland. I'd like to go with her on her next visit and ask some questions. What questions? Should she be ready for dialysis or?
Question, Dr. Hall.
Yeah, it's definitely getting close to that time, and depending on the cause and what she's doing to manage the condition that may be driving that process, I think it's definitely something her doctor should probably be discussing, preparing her for.
Go ahead, please, Dr. Pryor.
But just make sure that she's given all the options. Please make sure you ask what options she has if she needs any renal replacement therapy, because she does not have to have a catheter put in her chest and thrown into a dialysis unit. That's not the only option.
I just want to add one more thing. Thank you for being there for your sister. As a patient, I can say that for me, as a researcher, I knew to ask certain questions. I knew to look for information, but not everybody has that mindset, right? And so the community around them, along with their care team, is going to be very important, not only to their success in this, but also changing the mindset, right? Like around diagnosis and treatment as well. And so you even like being there and you being able to ask the questions that she might not be thinking about, taking notes, just really being that helping hand is really going to make all the difference. So I commend you. Thank you.
All right, we're going to have I want a take-home point from each one of our panelists. I want just one take-home point, and you're going to keep it brief for me, please. And we're going to start with you, Ms. Simon. The one thing you want to make sure that we take home an actionable item for us to work on. Go ahead. We'll come down the way.
Be your own advocate and get involved with your community. Seek a second opinion always. You can fire your medical professional if they're not doing like what they're supposed to be doing, because you too have a very active role in your healthcare journey.
Just be aware of the social determinants of health. 80% of what's going on with your health versus 20% of actual health care stuff that's going on. So just be aware and be an advocate for yourself.
Eat to protect your kidneys and have the fun foods in moderation.
Time is kidney. So give us the most time to work with to help curb the progression of disease.
Give a hand to these folks. And I want to give a hand to all you all for being out here and for some really wonderful, wonderful questions. At this point, I'd like to turn everything over. I guess, Deacon, you going to take us out? Or is the bishop? I'm just trying to make sure I'm covering all bases. I don't want anybody mad at me because he'll come up and correct me. I just saw what he did. He did and said, I don't want it to be corrected too. No, but Deacon Burke, thank you very much, sir. And again, it's been a pleasure for those of us here. I really applaud what you're doing here at Mount Airy. This is a wonderful, wonderful facility. And what you're doing for the community, sir, you guys, this is outstanding. Outstanding.
Can we give our moderator a hand? He's very passionate. First time I heard him speak, I said, man, this guy's got it. You guys deserve to applaud yourself. This is awesome. This is like, I would have never thought this many people would have shown up. Shame on me, but we're going to be back here next week, same time. The reality of our condition in our communities is we have not taken advantage of the outstanding resources that God has blessed us with. They're right there. And for whatever reason, that millimeter of skin brings a little doubt. And that should never happen. God is so awesome that he would give us. I mean, these folks are here on their own volition to make sure that we are educated, not just getting a pamphlet. This isn't a fair, this was an educational seminar. If you didn't get it from here, you can't get it. All right? So, speaking of getting, we're going to feed you. There will be food presented. If you go up the stairwell here into the fellowship hall, you can take your platter with you. It's a hot food platter. I believe it might be grilled chicken and salmon. I'm not positive it will be finalized. But it's healthy. It's healthy. And it's available to you. And I believe they went one step further, which my staff always does. They've set the tables so that you can sit down. Is that right, Sister Ruffin? They can sit down and they can eat. So if you would like to continue having conversation, you're more than welcome to do that. Our pastor has brought to us the whole notion of we are a community church. It takes a lot of energy, effort, and money to get it done, but we've been getting it done, and I could never be so more proud of my church. So thank you, Sister Gabrielle, wherever you are. When she first brought this idea to me, I was like, I don't know. And she kept calling, and she was after it. And Dr. Morris, who couldn't be with us, I believe she's online, Dr. Charlotte Morris, she has a heart for God's people and their health. She really does. And unfortunately, she's not able to be here physically in the building, but she is with us in heart, and she's taught me a lot about how important our health is, just like our spiritual growth. We have to take care of these physical temples that we have temporarily, until we rest in the arms of the Lord. Amen. So, thank you, panel. It was an outstanding job. You're welcome to get something to eat. I think some of you have to catch planes, so if you need to go, you can go before everyone else. Pastor Felton, do you want to have last remarks?
Thank you, Deacon Mark. We certainly appreciate each of you being here today. We are coming back next Monday. That's right. You're going to feed us next Monday, right?
Yep.
All right. So you know in advance what you're doing on next Monday. Our First Lady is here. Will you stand, First Lady Felton? We appreciate you on today. And so you remember when the older saints used to say, bless your heart. You ever heard anybody say that? You never heard anybody say bless your heart? Okay, so I want you to look at somebody and say, bless your kidneys. Yeah, that's what this whole session is about today, is blessing your kidneys. Because if you bless your kidneys, your heart will probably do better. And so why don't we stand as we close in prayer and break bread together. Eternal God, our Father, we thank you that you have favored us today with some of the best minds in healthcare and specializing in kidneys. And so we ask your continued favor upon them and the work that they do. And we pray that as we break bread together, that you will bless the food to the nourishment of our bodies in Jesus' name. Amen. Thank you. Thank you so much.